Our next speaker is Dr. Jason Baker, and as you have heard, and you will hear throughout this course, the survival of people with HIV is increasing significantly thanks to the advancements in antiretroviral therapy. Dr. Baker is associate professor at Hennepin County and University of Minnesota, where he looks at what we should do next, i.e., the persistent inflammation of people with HIV, what drives it, how can you address it for healthy and longer lives for people with HIV. So Dr. Baker.
Thanks, Roger. Thanks to the organizers for inviting me here. This is a bit of a homecoming for me. I trained in internal medicine, actually, at OHSU up in the Hill. So, and as Roger said, I do practice in a Ryan White funded facility, and so very much the same sort of practice setting that you all have. All right, let's see if I can. Good. I don't have any disclosures. I think you all received slides, so you can go through objectives. What I'd like to do is sort of break this apart in a couple of sections, talk about inflammation and clinical risk among persons with HIV, talk about inflammation with advancing age, just in general, this concept of inflammaging, talk about how HIV disease influences that process, and then some implications for clinical management. So I think this slide's a nice way to sort of set the stage of the problem. These data are from Kaiser Health Registry, and really 2 points. First, that persons with HIV are living longer, but they're having comorbidities for a greater percentage of that lifespan. So if you first look at the blue curves, that shows life expectancy here starting from age of 21. See if I can get my pointer. There we go. And on the x-axis, so starting from early 2000s and then looking at how things changed over time. So again, this is expected life remaining from age 21. You can see a mortality gap of about 20 years that is narrowed to 9 years with starting at age 21 about 2015. So during that time frame, though, looking in the orange bars, you can see that the onset of first comorbidity, which are listed here on the right, actually happens sooner in those with HIV versus those without, and that gap generally hasn't changed much. When looking at folks who start treatment above CD4 counts of 500, that's a smaller gap, but the bottom line is patients are living longer, but they're spending a greater proportion of that time with one or more comorbidities that are happening at earlier ages. And so what comorbidities are there? These are data from a number of trials together. These are basically patients that are on continuous antiretroviral therapy for about a decade, and about 80–85% of what serious events that occurred are non-AIDS defining, and about a third of those are CVD, a third of those cancer, and a third of those other. And if you look at other cohorts, some of those numbers change, but in general, you see these same types of proportions. And in this group, was remarkable is if you measure inflammatory biomarkers, here just interleukin-6, for example, at study entry, those with higher levels versus lower levels had greater incidence of these diseases over a decade of follow-up. So the implications are that you're kind of assessing an inflammatory state or tone that has implications for disease risk over the next decade. And of course, in the last 10 or 15 years, there's extensive epidemiologic data which have really shown greater inflammation, increasing risk for a variety of end organ diseases, probably the most common all-cause mortality, non-AIDS and AIDS and CVD events, but as well a number of other end organ diseases, from diabetes, cancer, bone disease, lung disease, and polymorbidity and frailty phenotype. But of course, this is not unique to persons with HIV. This relationship between inflammation and disease risk is really described in the general population quite broadly. Sorry about that. Let me go back. There we go. I like this image because it has sort of these two tiers. The first, these end organ diseases that can develop over time with increasing inflammation, but then actually that second tier is really with growing comorbid illnesses. You have multimorbidity, physical disability, the frailty phenotype. So there's additional consequences to longer time with increasing comorbidities. Okay, so thinking about more broadly inflammation with advancing age in this concept of inflammaging. So this was first described about 20 years ago, and really sort of the recognition of how systemic inflammation develops and increases with advancing age. And, I think it's probably obvious to most that inflammatory response is an adaptive or helpful response in the acute setting. It helps neutralize stressors or pathogens, and it's really important to protect the host. But it's really that sort of repeated stimulus or ongoing stressor which persists over time, which then sort of tends to push up an inflammatory tone. It doesn't have the opportunity of the host to resolve that, and perpetuates growing inflammation over time. In this model, they describe it as largely an innate immune activation, manifested largely by tissue macrophages, with injury at the tissue level, increased cytokines, and damage at that local level. But you can look through blood measures, and there's sort of characteristic sort of profiles, if you will, of immune measures in the blood, which are characteristic of this process and sort of inflammation with advanced age. And I will note the effective HIV. This is probably something you might want to remember if you're asked in the future. The effect of HIV on these sort of profiles of immunologic aging is that they're higher or more deleterious, if you will, in the setting of HIV disease. And in this model, what's sort of driving this chronic increase in inflammatory tone is ongoing stimulation or antigen stimulation or basically immune stimulation. There's a number of factors which are discussed in the context of inflammaging, and I'll just kind of review several here as sort of examples of over the lifetime what sort of is cumulatively adverse towards this process. So nutrient excess is brought up a lot, and we could probably do the whole half hour on this, but I'll just sort of highlight two considerations. I think one is, which might not be obvious, but it's we sort of, when we ingest food, our body has actually adapted to think about also being exposed to pathogens at that time. For much of our sort of evolution, we ingested food at the same time we ingested pathogens. So an immune response, an innate immune response, is actually quite adaptive in that setting. And with excessive stimulation of that over time, that can be deleterious. And also with increasing adiposity, with nutrient excess, you get adipocyte-mediated inflammation. Adipocytes and macrophages actually share a lot of effector function overlap, and so there's a large immune component to that. The issue of gut dysbiosis is widely hypothesized to be associated with increased translocation, which could, with bacterial products, be driving innate immunity. This issue with aging of increasing exposure to self-antigens, or so when tissue has injury in the short term, resolution involves the innate system sort of gobbling up cell debris and different things. But when that balance of debris generation and resolution tips towards chronic, it can be an ongoing source of stimulation. There's also genetic changes that happen with advancing age. And I'll just flag clonal hematopoiesis is something I'll kind of come back to as something that HIV affects as well. And it's an example that sort of feeds into this mechanistically. And of course, I think it's appreciated by most now that social determinants and health disparities, whether it's financial stress, food insecurity, environmental exposures, lack of access to services, really over many years can be a source of ongoing stress, which actually feeds into this process as well. And of course, chronic infections, and such as HIV. And so many of these things actually are brought up in discussions about chronic inflammation in the setting of HIV, because HIV either in some instances directly mediates this or is co-associated, if you will, with many of these same factors. So if we kind of bring that model together, I kind of like this. I'm a visual learner, so I kind of like this schematic as a way to sort of think about inflammaging as this sort of progressively increasing inflammatory tone with age. And with that ongoing stimulation, the sort of resilience or capacity to resolve is impaired, and it compounds to the point where disease develops in a specific end organ. And what happens then with that disease development is actually becomes a positive feedback towards driving more inflammation. A classic example is atherosclerosis, which itself is pro-inflammatory once it develops. And so this progressive inflammatory tone mediates the development of end organ diseases, which then starts to feed back as a positive loop on this whole process. And so in thinking about this in the context of HIV, how does HIV then influence this pathway? And again, bringing this immune profiling back over, and each of these factors really is sort of increased or mediated in the context of HIV. I'll just show one example, thinking about measurement in blood of levels of inflammation or coagulation activity. These are old data now, actually, from SMART and an HIV cohort or trial, which in this case was measured those just levels at one time point compared to uninfected persons in MESA and CARDIA. And even when restricting these comparisons to those that had suppressed virus, you see about 50%, give or take, higher levels of CRP, IL-6, D-dimer in those with HIV. And in the interest of time, I won't go through all these others, but the similar epidemiologic data has really shown cellular activation on the innate adaptive side, as well as cellular senescence phenotypes, are all increased in those with HIV infection. Okay, so I told you twice, I'll say it again. Those are all increased in the study of HIV infection. Okay, so I do want to spend just a minute then delving into an example of these genetic changes. So this concept of clonal hematopoiesis is, I think, really important in this conversation. So genetic mutations occur through advancing age. I think we appreciate that. In this model, thinking about blood lineages or leukocytes, some mutations that occur can have proliferative advantage, and those clones then can expand. Some put at risk for malignancy generation, but even in the absence of transformation to malignancy, you can get expansion of clones with proliferative potential. And in the setting of hematopoietic stem cells, that's clonal hematopoiesis. And some of these expanded clones then also have those genes which are implicated for increased proliferation, also are genes that are involved in regulation of inflammation. So in this sort of cartoon example here, it's sort of a TET2 deficiency. So this is a loss of function mutation in a monocyte. So this clonal expansion then involves a more pro-inflammatory set of clones where you've got increased transcription of cytokines and the development of the inflammasome, and that sort of pro-inflammatory clone then increases as part of this process. And it's been shown now sort of repeatedly in multiple contexts that the development of clonal hematopoiesis with certain of these key signature mutations is associated with increased risk for atherosclerosis, heart failure, and other cardiovascular pathologies. And increasingly seeing data now come out that these mutations are more common in persons with HIV. So these data are from Archive study. There's just over 200 patients with HIV as well as 200 without, and actually about an odd ratio, just over 2 of increased likelihood of having these clonal hematopoiesis. And it's very low numbers out at the right side, but some suggestion too that we do see these increase with age, and maybe even the effect in the setting of HIV might be magnified with advancing age. So the important thing here is that this really provides a mechanistic link by which HIV disease might mediate or accentuate some of these processes as seen with inflammaging and an increased disease risk for diseases that are mediated by that inflammation. Okay, so bringing that back in, again, another visual model. It's like the way I think about things like this sometimes. So this, if you think about, patients having different age trajectories in terms of their inflammaging, there's a lot of heterogeneity there, and events early in life can influence sort of the steepness of that or the trajectory. And in this context, you draw a threshold where there's a development of an end organ disease, and as I mentioned, sometimes that trajectory then actually becomes more steep once disease develops and can beget more end organ diseases. And so our goal is really to try to delay that, but HIV disease, in some sense, is shifting the curve to the left and steepening that trajectory. Okay, so implications for clinical management. So there's been a lot of randomized controlled trials over the last decade to try to target inflammation directly or indirectly in this context. And 2 strategies that have been taken are, to either target mechanisms specific to HIV disease the sort of disease pathogenesis of HIV that might be involved in driving inflammation, and other strategies targeting traditional risk factor modification, which by therapies that might also have anti-inflammatory properties. And numerous trials have really taken these strategies. You know, some of these have shown some reductions in some measures of inflammation, others no effect at all, but none of them up until this year, up until the pitavastatin trial, have really sort of manifested much in terms of changes in clinical practice, whereas I think the REPRIEVE trial really does become something that warrants discussions about change in practice, and I'll just sort of like tee that up for Dr. Grinspoon to pick up in a couple of talks. And I think a really pivotal trial about a potential risk factor modification strategy that overlaps with a lot of what we're talking about here. The other area in terms of pharmacologic strategies is directly targeting inflammation. And this has also been something investigated quite a bit, either directly targeting inflammation or in this context they laid out anticoagulation. But just wanted to highlight one trial that's actually a general population trial, but I think is really important kind of proof of concepts in thinking about direct anti-inflammatory strategies in the context of this disease risk. And so this was CANTOS. If those of you aren't familiar, it's a very large clinical outcome trial of 10,000 patients. These are patients that had already had a myocardial infarction and were inflamed, and so their CRP was elevated. And it's really looking at a decrease in inflammation as secondary prevention of heart disease. And so they studied a drug called canakinumab, which is an IL-1 beta inhibitor, as a direct, broad anti-inflammatory strategy, and really showed that there was a reduction. Here's the Kaplan-Meier plots for canakinumab at 150 milligrams as 15% reduction, and when all those doses were pooled together, about a 12% reduction. So it's not it's a modest reduction, but I think important that you're, as a direct anti-inflammatory strategy, reducing risk of CVD. So I put over on the right, really that this drug lowers CRP, has no effect on LDL. So that's the first kind of, I think, important observation is no effect on LDL, but lowering inflammation does reduce risk for heart disease. But as you can see back over on the table, it also decreased risk for cancer death, largely by decreasing lung cancer rates. So that's also important for other comorbidities. But then on the flip side, in terms of harm, there was an increased signal for risk of death from infection or sepsis. So the total effect on all-cause mortality was no. And so while a potentially important strategy of reducing inflammation, I think there is a risk side. And when thinking about population with various degrees of residual immunocompromised state, those with HIV, it really is a tricky balance to know how these types of immunomodulatory strategies are going to be net beneficial in this context. But I thought an important study to sort of think about that because I think will be continuing discussed in future trials. So with the remaining time, I want to pivot just a little bit and talk about moving from treatments that I think historically we study in trials that are really disease-focused therapies. They're really trying to treat a specific organ to increase lifespan. A lot of times it's trying to sort of prolong life after disease develops. Sometimes those disease-specific treatments are trying to prevent disease occurring as well, but in large part they're focused on lifespan, if you will, not necessarily prolonging the period of disease-free or active lifespan, or sometimes called health span. And that's a slightly different sort of focus or lens to apply, which is focusing on healthy aging and thinking about ways in which we can sort of keep that inflammatory tone lower in one sense, or delaying the onset of diseases, sort of regardless of the impact on total lifespan, is trying to increase that active lifespan or health span. And it's through that lens that I think a lot of discussion in the neuroscience world is really focusing on how can we target pillars of aging. And so this is a concept of thinking about sort of either mechanisms or changes that are kind of true across the development of multiple end organ diseases. So inflammation is one of those examples of a pillar of aging, where targeting that, the thinking is you can have impacts across multiple diseases, and actually if you can delay the onset of comorbidities, you can delay the onset of other comorbidities in some of these aging phenotypes, like frailty or multimorbidity. And there's a number of candidates that are looked at in this context. And I'll just sort of highlight physical activity is one thing I think we all appreciate the benefits of, but actually is something that I've thought a little bit differently of with some recent data and having discussions with patients around. And so I think widely sort of understood and accepted physical activity is beneficial. We understand this across multiple diseases. It improves quality of life. It improves mental health. Studies among those with HIV, certain strategies actually have been shown to lower inflammation as well and have similar benefits. And there's large sort of public health guidance established about the benefits of exercise sessions and achieving certain targets of exercise per week and certain types of exercise. And I think that's been, it's I think, penetrated that this is good and something we should strive for. One of the things that sort of motivated me to bring this up is that in my discussions, there's, I think, creating a binary sort of achievement or target actually can be somewhat limiting for those that just are never going to achieve that target or fail to achieve that target, and then it sort of becomes a negative instead of a positive of discussion. So I thought these data came out this year and sort of really crystallized, I guess, what I'm trying to say, which is the sort of continuum of benefits of physical activity. So these are a meta-analysis which over 200,000 patients, 17 cohorts, where they looked really at daily step counts at mortality risk. And you can see from the forest plots that all the trials, in terms of the top box there on all-cause mortality, similar to the left of the line showing decreased mortality with increased step count, and then CV mortalities in the bottom, decreased CV mortality with increased step count. But there's a couple, I think, really important things about these data. It's the first of it's a continuum. So it's really about benefits across the continuum of activity. And it's about a 15% reduction in all-cause mortality with each 1,000 increased step count daily, and about a 7% decrease in CVD mortality with 500 step count. But most patients probably get 4,000 to 5,000 steps per day if we actually measured those. And so increasing just up to 6 or so actually has substantial mortality benefits, regardless if you're achieving some 10,000 steps or whatever sort of ideal target. You have benefits. And actually, among older patients over 60, at the lower end of that activity, there's actually steeper benefits for moving from very low activity to just a little bit of activity. So that notion that this whole thing is across the continuum, I think, should shift the way we think about talking about that. The other thing about this, the second point that I think is important to call out, is these are not exercise sessions. So this isn't, you don't have to have a dedicated exercise session with X numbers of weeks. It's literally just moving more. And so this concept of lifestyle physical activity, I think, is discussed sometimes, where it's just about less sedentary parts of our day. To get 500 steps is 10 minutes, and in some cases, maybe longer for some. But the point is, you can work that into your lifestyle. You can park at the end of the parking lot. You can take the stairs. You can take a really long way to the cafeteria and back. So this whole notion that you need exercise sessions and strength training or aerobic stuff, I think, while obviously good, it shouldn't be sort of a binary way that we think about this when talking about patients, with patients. And so obviously, bringing back to this model, our goal really with all of this is to sort of push that curve back over. If we're intervening or having these discussions before the development of diseases, we're hoping to decrease that tone and delay the onset of those diseases. But even if diseases develop, delay the onset of the next. And so I think there are some things that have sort of established benefits in these contexts. There's clearly risk factor modification strategies that are important for us to continue to be mindful of and implement, but increasing physical activity, ways to reduce caloric intake with or without pharmacotherapies that have recently become popular, and a lot of behavioral interventions to identify barriers, depression, mental health in this context are really important. But we do need research in this context to really have interventions that target some of these pathways more broadly, beneficial across multiple diseases. So in summary, I hope I've shown that persons with HIV have a greater proportion of their lifespan spent with these comorbidities that develop earlier and ultimately then compound with age-related phenotypes, decreasing their health span or period of disability-free lifespan. that immunologic aging, characterized by increased inflammation, is increased among persons with HIV and influences a wide spectrum of disease. And then, strategies that can reduce inflammation in this context, optimizing medical management with risk factor modification, healthy behaviors, but the need for novel strategies in this context. I think that's it. I will just, I think we all are motivated by and inspired by the people we work with. I'll call out Carrie Sheets on this slide, who's a geriatrician who works HIV and Aging clinic in our facility. It's really sort of helped us to develop some of our approaches and the way, and my thinking in some of this talk. So thank you for your time.
Thank you so much, Dr. Baker. I was expecting Dr. Sag on the podium, but he's right there asking questions.
It's a wonderful talk, Jason, fabulous. And what you brought together was how inflammation is sort of the root of evil, but it's also some good, right? Because if you suppress it too much, then other bad things start to happen. So finding that balance, what you also did nicely was talk about what kind of pharmacotherapies can we use. So I have two drugs I want to put out there. You mentioned statins. We'll hear more about that from Dr. Grinspoon a little bit later. What about the new drug loss medications like semaglutide or metformin? Can you see a role for them in the long run, or is it just the weight loss is the benefit, you think, or is there something else?
You can hear me? Okay, there we go. The GLP-1 agonists and metformin. So, with the weight loss drugs, the appetite suppressants, I think in one sense, this might be similar to statins. Statins do two things, right? They lower LDL, and they have evidence of an anti-inflammatory property. Those two things you can't decouple. So when we test the treatment effects, we see both of those things happening. With GLP-1 agonists, maybe somewhat less known in terms of anti-inflammatory effects, but I think you're probably going to get multiple things happening. And in one sense, that can create a lot of discussion and be confusing as to why things are happening. But in another sense, from a practical sense, who cares why if you're hitting things at multiple pathways and you're having a greater clinical effect? We know that nutrient excess, weight gain, is detrimental in a lot of ways, and one of the ways is by increasing your inflammatory tone. So if you're decreasing caloric intake and you're decreasing weight, you're probably going to get benefits all over the place. I'm not sure if I'm answering your question. I don't know why, but I think it's probably going to be beneficial in this context.
And your last point was also key, that somebody loses 30, 40 pounds, their activity is likely to pick up, and that's, as you showed nicely, is very good for folks. So it's all good.
Yeah.
So no lunch today. So, okay. Any studies looking at structural interventions on inflammasome, e.g. housing stabilization and inflammatory markers?
In terms of specific interventions, one of the things I sort of resisted was to do a laundry list of, in some sense, because there's so many, I think, interventions that have been being studied right now. And a lot of those are looking at sort of immunologic intermediaries. And so I'm not sure if I can call out any specific examples targeting the inflammasome, but I think that's a kind of a robust field that seems to be increasingly studied as just ways to sort of mitigate that pro-inflammatory drive, and whether it's effects on an inflammasome or other direct cytokine, monoclonal antibodies. I think the thing for me is how much, like Mike Sag mentioned, how much immune suppression effect are you getting in addition to that anti-inflammatory effect? And so when we see a lot of phase 2 level studies, but if we're going to sort of advance those along, I think having comfort that we've got that balance right is, I think, some of the key.
All right. Yes, please.
Thank you for the presentation. I am from the Virgin Islands. I have a large subset of patients who are not necessarily accepting of Western medicine. So I guess my question in a nutshell is going to be, what is the research showing for not so typical medicines for anti-inflammatory, more natural components that some of my patients will be a little bit more accepting of, and particularly, for instance, things like CBD, marijuana, etc.
Yeah, that's actually a really good question about specifically CBD. I'm not sure I can speak to data specifically about herbal or other medicinal, that it would be sort of non-FDA pharmacologic interventions, if you will. I do think that, and maybe I'll indirectly answer it by saying things that either behavioral interventions or things that are addressing barriers that increase the likelihood that people are going to want to get out, be active, decrease depression and anxiety, can be very beneficial. So either directly by decreasing depressed mood, decreasing anxiety, that itself can be less of an immune stress, but also then you're increasing your social connections and you're increasing your activity, which has positive benefits. So in terms of its immune-mediated mechanisms, I guess I'll pass, but I do see that there's a lot of possible benefits along these themes for many of those strategies.
Excellent. Now a question. Plenty of data showing effectiveness of whole food, plant-based diet on CVD, diabetes, etc. in general population. Any data done on HIV population?
Essentially, dietary strategies reduce, yeah. I guess my view of it is it's probably no reason to think that the same strategies aren't beneficial among those with HIV. So if we think about, and Steve may speak to this in his talk about REPRI, but if we think about HIV, persons with HIV having increased risk for cardiovascular disease, a lot of that involves the same pathways and mechanisms that involve cardiovascular risk in the general population, but there's maybe an added sort of accentuated component with increased inflammation. It doesn't negate that all those other things are important. So what's beneficial in the general population is probably beneficial for our patients as well.
That was a great talk, thank you. Quick question, you had a few slides maybe that mentioned mitochondrial toxicity, but you didn't speak to it specifically. And back years ago when we used all the D drugs, that was sort of a big talking point, although I don't remember getting anything really out of it as an answer. When I did oncology, the thought was that a lot of chemotherapeutic agents cause mitochondrial toxicity and thereby sarcopenia. And so I ran an oncology rehab program for a while. And we were working on a study like that, but bottom line, it was kind of the thought process was, again, that sort of an anti-inflammatory diet and exercise were the answers, both pre-chemo at that time and post-chemo as a sort of a rehab. Just any thoughts on that with HIV now?
Yeah, so with a lot of the evolution of newer drugs and some of those toxicities being less, I think you're right, that has gotten less attention. Some of what I kind of went through fast, but a lot of this, the notion of an increased inflammatory tone, there's probably multiple ways to get there. In some patients, it may have been drug toxicity from earlier on when they were treated. In other patients, it may be more nutrient excess. But I think it's still important, especially many of our patients did get treated during time periods where the drug toxicity was greater. So I think it's an important part of their cumulative history to where they're at now with risk. In terms of, you kind of alluded to interventions, or I didn't talk a lot about sarcopenia and some of the other sort of aging phenotype, whether it's considered part of the frailty phenotype or other decreases in physical function with aging, which can be a consequence of multimorbidity. But I think that is a really important point and can be very limiting in quality of life. Activity can be helpful for muscle mass gains, but if the goal is really lean muscle mass gains, probably more specific structured exercise and strength training is probably important in that context.
Yeah, I'll get to the podium, but a related question on biomarkers. What is the best risk calculator, the question says, for inflammation?
Yeah.
So what is the best biomarker? Is there one?
I spent probably more time than you guys care to know thinking about individual markers and inflammation. I think what's important to remember is that a risk predictor is one thing, something that associates with clinical risk. A mediator is something completely different, which most of these predictors are not necessarily mediators, which means that you may or may not be able to mediate risk by intervening on that biomarker. So to be a risk predictor is a little easier than to be a mediator. And so what's the best marker? It kind of depends how you're trying to use it. And also, in thinking about clinical practice, to what degree do measuring these levels actually have added value to our risk stratification? And that's been, it does seem like you can probably get some increased risk prediction with some markers, but you get a lot of your risk prediction just through traditional risk factors as well. So I'm not going to go on record for one marker versus another, but I really think it depends on kind of how you're using them and what your goals are.
Fair enough.
Hi, I'm Elliot Goodenough from Philly. I just wanted to make a brief comment about weight loss advice in general. I think we're all eagerly following GLP-1 evidence, but it's important to also consider weight loss advice in general and its effect on our patients' experience of stigma. And so I think it's possible for us to separate nutrition and activity advice from weight loss advice, and consider that a lot of our patients have experienced discrimination related to their fatness, particularly from doctors, and that may itself increase their inflammatory profile.
No, really, thank you for that comment. No, I thank you for that comment. I think that's really important, that weight and nutrition are not tied that way. So I really appreciate that.
So, adverse effects of alcohol are getting more attention lately. Could you comment on the risk of moderate alcohol consumption on inflammation or aging? Can we just drink a little bit?
Roger, so one of my first attendings always told me everything in moderation, including moderation itself.
Well said. So, do you have any data on this aging inflammation process in preliminary or perinatally infected patients?
Oh, perinatally infected.
Yeah. Once they reach the age of 21 years, they often have comorbidities already, metabolic disease, etc. So they've been living with HIV for a long time by then.
Yeah, no, that's a great question. Actually, offhand, I'm not sure I can cite any specific data, but I mean, I think thinking about some of this as cumulative over time, it certainly is potentially a group that might be at more risk.
Okay, so is there a correlation between inflammation and the and robust CD4 response, more than 1,200 or so? So does inflammation correlate with the magnitude of CD4 response?
Yeah, you know what? That's a great question. So just thinking about things that sort of predict more robust CD4 increases, obviously where you start antiretroviral therapy is the best predictor there. But there, in general, if you look at large cohorts and you look at the degree of immune recovery, there is an association with inflammation for less immune recovery. It's from much of the data I've seen, it's modest. It's not large, and so I don't think it's a. I think there's overlapping factors and mechanisms to both, but I don't know that a lack of immune recovery itself is a major driver. But yeah.
If there's no more questions, thank you, Dr. Baker. I think.